Hey, folks, good morning slash midday, depending on where you are. Can everyone hear me okay? Yeah, okay. I can't tell if I can hear you, but I think so. Yeah, I can hear you. Okay, perfect. Um, well, so nice to be with everyone. There were a number of requests to record this because some people aren't able to be here for Rosh Hashanah, etc. So if that's okay, I'll do that. But I am so glad, or actually, Gail, if you don't mind doing that, that would be great. Um, if I'm so glad to introduce Dr. Astrid Grouls, who many of you know, who is a tremendous palliative care physician and has been doing some really interesting work about and thought around financial toxicity that impacts our patients and families facing ALS. So I'll just hand it over to you, Astrid. I think it was going to be a conversation as well as seeking some ideas about her planned research. So thank you.
Yeah, thank you so much, Cara, for the introduction. I am going to, oh, it's always a little bumpy when I start a screen share, but here we go. There we
There we go.
go.
Brilliant. You did it.
All right. Thank you guys
Cool.
for being here today. I'm really excited to talk about this. And here on just this very first slide, I put this word discussion in red just to remind me to really say that this really is intended to be a discussion, not a presentation. So I hope that we'll take pauses as much as I try to remember to do them. I'm bad at it. And really looking forward to everybody's input and experience. So some things that I'm going to start by covering is kind of where this interest in financial toxicity came from, what we know in prior literature about this, what's in the literature now, and maybe some next directions and steps. And that's really where I'm looking forward to hearing from each of you. Um, I got interested in financial toxicity and the expense of having ALS as I got introduced to the multidisciplinary ALS clinic. And the first way for me that happened was as an inpatient palliative care physician. I was getting a lot of referrals and consults for people living with ALS when they ended up hospitalized, and we were having discussions about tracheostomy and ventilation, really in that acute inpatient setting. And that's when Dr. Sharp, the neurologist here at Baylor College of Medicine, said, hey, maybe we should be moving these discussions into the clinic and get you into the clinic. And since I've started there in May of 23, I've learned so much about the equipment needs, the additional needs. Of course, there was the Relyvrio market withdrawal and kind of thinking through that. And all of those things had me start thinking about what is termed financial toxicity and some of the other spaces that I work in. So when I say financial toxicity, what actually is that? It was a term that was actually introduced in 2012, and it's at that time they said it's the cost burden associated with cancer treatment. And they said, toxicity is a term that all of our oncologists know. We think about chemotherapy toxicity, radiation toxicity, and so they kind of put that term there together. As a way for oncologists to conceptualize the cost of cancer care and the other impacts that this has outside of some of the physical symptoms that we might be thinking of. And since that time, the literature about financial toxicity has really been broken down into a couple of different domains and a couple different ways that we can think about it. On the left, we have the model by Carrera and Zafar. Again, it's in the context of cancer that breaks down financial toxicity into what we think of as objective financial burden. So really thinking like dollars and cents, what people are spending or no longer making in income versus the subjective financial distress or the experience that people have as a result of their financial situation from their illness. And I liked how White and colleagues on the right side broke down subjective financial distress into kind of material, psychosocial, and behavioral categories with different coping mechanisms, how it impacts your day-to-day function, the decisions that you make about any medical care needs you have, and how those things all interplay into financial toxicity. So, as I was thinking about financial toxicity among people living with ALS, I was like, surely there's something out there because I can't be the first one. And of course, I'm not to think about how expensive this is. And I was like, how far back does this literature go? So, this is an article. I'm a little interested in medical history, so I'll pull that in a little bit as well. So, this is an article back from 1975. It was published in JAMA, and it was all about the symptomatic care of people living with ALS. And even in this article, they mention, and I like this quote, there's a clear need for development of extended health insurance to cover such patients so they can spend their last days in dignity, free of worry about cost. So I was pleasantly surprised to see that even in 1975, we were starting to think about how expensive ALS is. But I don't know if there's been a lot of progress in that conversation since then. So, kind of looking through some more literature, in 1986, there was this publication. It's a smaller journal, and it was printed in Great Britain. And they looked at the illness experience for people living with ALS. This was a 12-month longitudinal study, or interviews, if you will, of two people living with ALS. And in the introduction, they do kind of a fair bit of literature about ALS, and they mention the costs for at-home care. And the participants, the people who were interviewed, did mention just kind of the cost of care, foregoing treatments that might be available to them because of the cost, um, the importance that both the patient and the spouse are retired, so that they didn't have to think as much about the cost of hiring caregivers, and that you know device costs. So this conversation was already starting in the 80s as well. And over time, this kind of continues. There are 1993 and 96 papers that literally focused on like the cost of the equipment itself. In the 2000s, there was some discussion about the high out-of-pocket costs that people living with ALS are facing. Including 2009, there's an article from the Netherlands where they had people collect a 6-month cost diary. And in that, they started to capture indirect costs. So, like lost labor, how much less money people are making because they've had to cut back to part time, either themselves as someone living with ALS or as a caregiver for someone with ALS. And in the teens, 2010s, we started seeing papers on the economic impacts more on a national scale. Um, for on a kind of a whole country basis, what is the expense of ALS through Medicare and things like that? What's the overall economic impact? And the ALS Association, of course, has started to do some good work in this space as well. So they started doing those focus surveys, and cost of care came up in this as well. So this is the first focus survey, and you can see one of the points that they made here was that half of respondents living with ALS stated that understanding medical insurance coverage and dealing with medical paperwork impacted their stress level substantially. So we're starting to see more research here on that subjective component of financial toxicity. They did another survey on insurance and payment for ALS care. This was in 2022. Fabulous. You can see of 62 participants who were denied insurance coverage for things, of course, about half cited worry or stress as a result of that. A third cited caregiver challenges. 31% reported financial burden. And you can see the top 5 insurance denials are things that are really commonly used. So it's not really a case-by-case basis that this is coming up. Prescription medications, wheelchair accessories or power wheelchairs, PT, OT, speech therapy, and then of course wheelchair accessible vans. So these are definite issues for people living with ALS. So I've done already a lot of talking here to open this up, and I wish I'd had a case here specifically to bring to you guys, but I just don't. So I wanted to open the floor a little bit here to initial reactions or seeing if what we've got here kind of fits with your experience.
I think one of the things that wasn't included there that was really big for my family was the cost of in-home care.
Mm-hmm.
It was exorbitantly expensive. Um,
Mm-hmm.
and so we made a decision that we really didn't do that until we absolutely had to.
Yeah.
Jessica has her hand raised.
So yeah, I'm actually just in the process of pulling out, you know how we did this global fundamental rights survey in 2023, we're doing the next iteration in 2025. And we did ask the question at a global level. I'm sort of trying to pull out the data as I speak. We asked about the how ALS-MND has affected the economic situation.
Mm-hmm.
And we had statistically significant countries. We had Turkey, Brazil, Spain, the United States, Australia, Canada, Colombia, Japan, the Netherlands, Denmark, and Korea, which were the majority of, and we had like sort of from all over the place, but those were the heavy regions. And just sharing to you what at a global level we found out, and it was that
Mm-hmm.
over 4 in 5 persons with ALS-MND have been affected economically. That's 81% of those that responded. The largest gap in economic change was between non-English respondents, with 85% were affected versus English speakers, 71%, although both numbers are high. And by country, the most affected economically were out of the statistically significant countries was Colombia, Korea, and the least affected were Canada, Australia, and Denmark.
Hmm.
And we had that, yeah. So we hope on the next survey check, we're still deciding what the drill down is, but we have found that, especially in the global South countries, it is pretty dire, the situation
Yeah.
of how the financial strain that ALS has, in particular with the decisions that they have to make, sort of, it's almost like which pound of flesh they have to pull out, they have to
Mm-hmm.
cut off kind of thing. So for example, even with access to Riluzole, like it's not a cure, but it helps in a way, and psychologically and mentally it helps people, emotionally and psychologically, that they're taking something that could help in some way.
Yeah.
But it's not always accessible in those countries, and even paying for it privately. In some places, it's like, I remember in Asia Pacific, I think it was in Vietnam, it was three monthly salaries to get like 1 month's worth of Riluzole. So
Mm-hmm.
do you take Riluzole versus you agree against, to pay for your therapies or for any other type of multidisciplinary treatment that they want to follow, or not even treatment, care, or even just quality of life utensils.
Mm-hmm.
I'll just bring the global perspective here
Yeah.
from what we have sort of heard from our community. Mm.
And I think one thing I'm really hearing you saying, and one thing I see popping up in the chat too, is just how much this might influence care decisions. If and I don't know if there's and please correct me if I'm wrong, but I don't know if there's a lot published on kind of how people are navigating the cost and those decisions. I see another hand raised.
Yeah, Jerry Current. Yeah, thanks, Astrid, for focusing on this really critical area of patient care and family survival in many cases. I just want to make two minor, well, one's an important in particular, and that is the stark difference in the economic impact of ALS, whether you're a veteran with service-connected disability for ALS
Yeah.
or a non-veteran. And having worked in clinics in both the university and more recently in the VA, it is absolutely astounding. It's black and white, day and night. Um, Largely spared as a veteran with ALS because of the service connection. There
Mm-hmm.
got to be any cost for DMEs, for medications, for clinic visits, basically nothing, and absolutely a disaster for many patients who are non-veterans and don't have the benefit of that. So that leads to the second point. The National Academies recently concluded about a year and a half body of work, 18 committee members, and focused a good deal of attention on the economic burden that encompasses many different areas of patient care, including caregiver indirect costs, leaving their job, cutting back. So they provided a particular focus and hope that Congress, when they read the report from this committee, will make some effort to direct attention to at least the insurance industries and other sectors. There's no mandate to make a change, but it's certainly going to bring this to the attention of a lot of people who can make some changes. So thank you a lot for bringing this up. It's a wonderful presentation.
Thank you. And I think one of the things that you point out, the patchwork system that we have in the United States of coverage, and just the variety in coverage between, this being a fully service-connected condition, and then, people with different types of insurance, different degrees of coverage, many people with no insurance, especially here in Harris County. I think that can make such research actually richer, but also perhaps more challenging to understand. Nuna, you've had your hand raised for a while. Oh, you're muted.
Yeah, I was just thinking like the kind of common thread. I agree as a VA ALS doc, it is a lot easier in some ways. I would say the common barrier and challenge that you highlighted both on the ALS Association slide and with my VA patients is the fact that, even if there are resources, a lot of times all the entities providing them are kind of siloed. There's not really a lot of crosstalk between them, and there's not really like a single ambassador who can kind of walk you through it. Those of us lucky enough to have a social worker to kind of explain the ropes and explain the structure of some of these systems is helpful. But I've noticed, if you think about the average age of onset, the fact that a lot of our patients are older and not very tech literate, they can't just go Google something. Like a lot of my rural vets don't have a computer or email. So the barrier to knowing how to fill out 3 or 4 pages or find the right contact or how to quote email it or fax it. They're driving to the post office to mail something, it gets lost. It doesn't occur to them to follow up on it. So sometimes there's a 3-month delay for service connection. So I imagine if that's how it is, even at the VA, which has layers of support and people who are, like used to helping people that have sort of low medical or tech literacy, it's probably that much worse out in non-VA world. So I bet that would be kind of the easy low-hanging thing to tackle, would be just kind of how do you sort of create a position, a person, a process, a handout, who knows what, but just a way to make it easier for people to navigate the resources that are there.
Amy, I see your hand raised as well. Great points, Nuna. Yeah.
Excuse me. And then there are the costs directly attributable to insurance delays. I know with my husband's situation, we couldn't get an insurance okay until he was already needing it.
Mm-hmm.
And then there was the, the bottlenecks in the pipeline. So we actually had to buy some equipment ourselves out of pocket to kind of close the gap before we got the real stuff.
Yeah. And there's some great additional comments being made in the chat about that this really doesn't end with the loss of the person living with ALS, because there's ongoing potential ramifications to the survivors too. And then, of course, there's a lot coming up I see about caregiver situations and caregivers taking steps back from their own work to provide caregiving needs. Yeah. All right, another hand raised.
Jerry again. Just wanted
Jerry,
to add
sorry.
just wanted to add to the highly relevant comment about navigating the system, and this is a good time to for a major pitch for multidisciplinary clinics, which we're very pleased to say we've had at the VA in Charleston here for the last 14 years. We started You've got on-site people that take the huge work out of navigating this if you're not close to a VA hospital, first of all, but particularly if you're not part of a VA multidisciplinary ALS clinic. So that greatly facilitates the whole process. It's incredible. I'll come back to the National Academy's ALS committee work and recommendations to Congress. The idea of problem really with insurance denials, pushback that were so eloquently described a short time ago. That was going to be one of the key recommendations to request Congress to see if we can get some insurance changes to really change what frequently are egregious practices across the board, and wish it weren't that way. But I'm pretty optimistic that some changes will be forthcoming. The whole pre-approval process, not just for ALS, but for patients across the board, has gotten, I believe, Congress's attention. So I think globally there's going to be some structural changes in how the insurance industry deals with pre-approval, just as one little item. Thank you.
Got my fingers crossed for that. And I wonder if that ties in with, I see Benjamin's comment about the AAN guidelines and if they should be more proactive regarding DME and home care support, which is a great point, kind of what roles associations can take to help make some, quick turnaround for some of these things, maybe the standard of care. Yeah. As I was as I was thinking about this this question myself, I was thinking back to those models of objective financial burden and subjective financial distress. And I think, I know there's active work going on direct costs and indirect costs, really capturing that really for the person living with ALS in that immediate moment. But a number of the points y'all made were on my mind as well, the caregivers. And also I worry that the literature on capturing the subjective financial distress just isn't there. I think we've all probably seen it in our practice or lived that. But that was a gap I was seeing as well. So I think some of these points were made already. And this was just me kind of like brainstorming things that we just don't know about the space of financial toxicity here. Like, is it as common among people living with ALS as in other serious medical conditions, or perhaps is it heightened due to the nature of ALS itself? Is it experienced the same way among all people living with ALS? I suspect not, given our patchwork coverage. What I was curious what efforts there were going on addressing this outside of the research setting. How does this impact treatment decisions, medication adherence, quality of life? And just a lot of these things are difficult to measure and understand better if we don't have a good way of capturing this and screening people for it. Amy, I see you raising raising your hand.
Yeah.
Great timing.
So my husband took Riluzole and I forget everything that was available. We live in Seattle. We're members. He was part of a multi-care clinic, and luckily we were told about foundations that would help offset the cost of these very expensive medications. And that made it possible. Even so, we spend hundreds of dollars a month on them. And it might be interesting to hear what they have to say about the need that they have found for, yeah.
And when you say they, you mean
The foundations.
the foundations. Okay.
Yeah.
Yeah.
How they assessed need and so forth.
Absolutely.
Can you be more specific? Sorry if I missed it, but about exactly what support they provided? It was help with the cost of the medications.
Cost of
Is that-
medications, yes.
Yeah.
And each medication had its own foundation that you had to
Yeah.
apply to. Some of them you had to remember to apply every year.
Oh
You know,
gosh.
do the paperwork.
Completely crazy. Yeah.
But you know, it was a godsend because they did
Yeah.
help. I wonder what percentage of people with ALS even know about that funding. And
Mhm.
I'd have to go back and look at my records about what we wound up paying even with that help. But it was, you know, it was complicated. Yeah, it was a mixed bag, but
You know, Amy, I can't help but wonder, you know, and we'll get to this part. I've got a little bit of data on trying to capture what's going on for our people living with ALS in our clinic and the efforts they have to make to get their cost concerns addressed. But a lot seems to be put on the patients and families, as if you're not going through a lot. Um, a lot seems to be put on patients and families of, oh, reach out to insurance, reach out to this foundation, apply to this and that. I can't help but wonder how many man hours people are putting into
it was
all
almost a
that.
full-time job, you know,
Yeah.
chasing down the facilities and what have you. And then there are all these weird glitches, like we applied for a wheelchair with a seat lift, which was necessary. My husband had one here in his chair at home. And because we had made the insurance application before, which didn't fund the seat lift at that point, um, uh, we made the insurance application, and then we applied to Team Gleason, which was known to fund that adaption. But because we did it backwards, we should have gone to Team Gleason first and then applied for insurance or something. But that made us ineligible to get that assistance for that cost. So there,
Oh.
you know, it's complex
Mm-hmm.
and very
Mm-hmm.
time consuming on top of everything.
Wow. It's crazy that just going in the wrong order had such an impact, as if you're expected to know that.
Yep.
Wow. Wow.
Exactly.
Christy, I see you raising your hand as well.
Yeah. Amy, thanks for being here. My question is really more directed at you, or for you.
Mhm.
But I was wondering if the foundation, if you know that if those resources were from the foundation itself, or if they were from pharmaceutical companies. As a social worker, I would help people apply for everything that we could find, including some pharmaceutical companies would offer discounts for certain medications. You'd have to apply for them and all of that.
You know, I don't know. I would have to go back and read up. I didn't do a deep dive, obviously, into a lot of these details, but my sense was that it was private foundations. I don't know what the funding source was in toto, but
Philanthropy. That's my understanding, is that generally it's
right,
private funding for resources
exactly.
specific for ALS.
Exactly. And Team Gleason, I don't believe it gets any federal funding. And, you know, the various places you can go like that, you know, go for expenses. So a lot of it is dependent on philanthropy.
That's a great point about philanthropy. I'm starting to kind of, and I didn't put a slide in here because the work is so preliminary, but looking into GoFundMe campaigns that people living with ALS and their families have put together, kind of what people are asking for. And it's you know, the avenues that people are going to try to get some costs covered. It's difficult for me to think about, you know, there's a risk that I'm going to run across, you know, one of my patients is putting together a GoFundMe page to cover their care. And, you know, it makes you feel a certain kind of way when you think that, you know, your people are having to reach out to strangers for help. Especially because I feel like in my clinical practice, you know, patients, as much as I try to screen for it, patients aren't really bringing up cost concerns, at least with me as a physician very often. I'm wondering if other people have a similar experience.
I agree. Sadly, I think a lot of people worry that there's not much we can do, you know, or that's what their experiences have taught them. But I do think that these questions come up a lot more with social workers, and I think it's really important to have a social work presence in the ALS clinic somehow.
Yeah.
I would feel like it comes up for me. It comes up for me when I am trying to figure out if I want to charge them to see me as a second physician, where I will defer like a visit, or I'll just try to say hi, hello, and not charge if I can. But it definitely will be in the back of my mind to try to be mindful of if somebody has difficulty, like if we get international patients who don't have insurance or uninsured patients, then I will forego my visit, which is not ideal. Minimizes access to specialists.
I've started kind of looking into this in our own clinic. So it's kind of a segue there. But I'm trying to see kind of what's being documented in our electronic medical record. Again, I'm in a multidisciplinary ALS clinic, so I think, you know, the experiences of people that aren't in a multidisciplinary clinic is probably quite different. And we're finding so far that most of the documentation that's coming about expense, particularly issues coming up at the change of insurance or sudden changes in formulary when or kind of what's permitted by the insurance. And most of this seems, at least in our clinic, to be coming up in between clinic visits with my chart messages and things like that are being screened out by or being managed directly by our MA clinic coordinator, and then being routed to, you know, as was pointed out, like a foundation or to Team Gleason or ALSA, what have you. And families are being asked, you know, reach out here, reach out there. I'm curious if I don't think anybody's done a chart review of financial concerns in their clinic, but if that fits with experiences anyone else has noticed it. Amy?
Yeah, I remember when my husband first got diagnosed, and we live in an area where the ALS Association has a very strong presence. And they sent us a series of little booklets about various aspects. And one of them was financial. And at that point, at the very beginning, it was kind of, we were just so overwhelmed by everything. I remember looking through all the books and kind of putting them aside to deal with, you know, as issues came up, whatever. But I remember that they had a book on the financial implications, and I'd be interested. I threw all that away when my husband died, but I'd be interested to know how much they've tracked that and updated that information. And also, the ALS Foundation, Association, I believe, was really critical in the Social Security changes that were made several years ago. That allowed ALS patients automatic access to Social Security rather than waiting those terrible few months after applying. And I'd be interested again in, you know, with this, with financial toxicity in mind, I'd be interested to see how if they've tracked that, and what went into that decision to begin with, because it was enough to have Congress, you know, make those changes. I wish they do it now for insurance. For me, that's the biggest bugaboo, the insurance delays.
Yeah. Is anyone in their clinic using like proactive screening for financial concerns? That's something I was curious about.
This is Sarah. I'm a social worker at ALS Center at Emory in Atlanta. It's a part of my psychosocial assessment at the beginning. And then as I move forward, sort of with regular assessments that I do when folks have first been diagnosed. And then as we see people every 6 months in our multidisciplinary clinic. I try to check in with them as well. And at that point, my hope is that they know me well enough from the first several months where I'm in pretty close contact with them that they know to call me. And I give them a pretty thick resource packet to look through. But to the point made before, I think it's so much to go through. I find that I have such great information in there, but people are just so understandably overwhelmed that they just don't even know that stuff's in there, and they'll call me and ask me, and I'll be able to refer to it, which is great. And so what I've found over my time is that I just try to gently re-reference to it each time I talk to somebody, so that hopefully they'll take a look at it, because there's likely something in there that's helpful, that you just wouldn't even know. I mean, there's help for folks who have parents with ALS and have they have college debt or whatever. Like there's just all different sorts of random things you wouldn't necessarily think about, that I try to put in there. So that's how I try to handle it. And then of course, when folks are really under-resourced, I normally know about that. Like that's normally something that comes up.
That's great that you are able to know that they have that in hand, though, even though they, people may need kind of reminders and pointers to the relevant part of that. That's great.
Yeah, and I try to encourage sort of the care partner, and maybe if there's another person that's involved that's sort of a little less overwhelmed, just when there's sort of a larger care support, I'll try to suggest that maybe, give all of this to them or whatever it might be, and perhaps someone else can kind of look through it for you. I will say with all of this, like I feel pretty discouraged just in general, because I think the reality of our healthcare system in the US is that it's honestly not built to take care of people. It's built to make money. And as long as we have a healthcare system whose purpose is to make money, like that's going to be the result. And these are going to be the issues we're going to continue to run into, sadly. So unless we really have large systemic changes, these are always going to be the things that we're facing, which is really hard. And so one of the things that I try to do at appropriate time, just sort of based on assessment, but as early as I can within that appropriate time, is to really let people know how difficult this is, especially the caregiver piece. That's the biggest financial strain I think that I see with our families, meds and equipment and all those things. But there's pieces here and there for help with that. It's really the caregiving portion that is just so expensive. That's really, really tough. And so I do try my best to educate people as soon as possible without, doing it at a place where like I'm just totally going to tip them over the cliff, because there's just too much. But the sooner that people realize that that's the reality, as horrible as it is, the sooner they can start to kind of restructure and reframe and figure out, okay, well, in light of that, let's, try to make the decisions that, are the best ones given sort of, really what's available.
That's a great point about not wanting to overwhelm people from the get-go. Absolutely.
Yeah, I don't want to. And also, like it's hard, right? Especially if you meet somebody and they're pretty far advanced, and so I think it takes a lot of skill to, just like when you meet somebody who the first time and you're diagnosing them, for physicians and the team, and you already have to talk about, respiratory goals of care, because that's just where they are. And I think a lot of it is just how we approach things with folks and how we offer them support. And I just try to do a lot of really close follow-up in those situations, as much as we can. And I feel the same way about finances. There's just, it has such a huge impact, and it's such a taboo thing to talk about. So I really try to normalize it as much as I can.
It is difficult for me also to think about, because the question has come up since I'm interested in this in our clinic, should we be doing more proactive screening? And it's difficult because there is some hesitation, because even if you capture something, it seems like we have resources to send people to, but it is putting it a lot back on, patient and caregivers, putting it back on their plate to do something. So I feel like it's a double-edged sword.
It is, but as a social worker, the way that I
Yeah.
try to frame it is that people need to learn this information, because the only way it's going to change is by our country making a decision for it to change. And that's by us, voting the appropriate people in and telling the people that we voted in what they need to do to make the policy change. And so if people don't realize, I think that's part of, from a social work perspective, of our code of ethics, and making sure that we're not just helping the people in front of us, but that we're really trying to affect the larger societal aspects of things that cause these social determinants of health and difficulty with getting care. And the reality is people have to be educated about it in order to actually approach policymakers to get it changed. And so it's not that I'm like, and you must call, I don't turn into, but I do it in a way of being like this is a really big societal problem, and I'm sorry that you are caught in the middle of it. And I wish that I wish I could tell you there was something that would solve this. It would be unfair for me to make you feel like there's something out there when there's not. I can show you the things that are there. And otherwise, this is something as a country that's really difficult. And, I sort of try to put it in those terms. And if people seem to become interested over time of talking, then I can talk about how they can advocate in a larger manner and be a part of that, which I think is also can be a meaningful part of being ill and not being able to, and I haven't, gone through ALS firsthand, as I know some of the folks on this call have, but with other illnesses and all the rest. And as I just sort of think through that, and from the literature that we know, and psychosocial land, that, when we find meaning in other places as we're going through suffering, it's really helpful and really important. And so even if we can't fix what exactly is in front of us, if we can turn that suffering into something that's actionable, there's a lot of meaning and healing that can come from that. So I also see it as a tool and a way of people being able to take action if they feel like they have, the emotional reserves for that.
Yeah, absolutely. Absolutely. Great points. Amy, I know you've had your hand raised for a while.
That's fine. I want to, I deeply agree with what's just been said. My husband died a year and a half ago. And particularly in the past year, I've been working on coaching people who's gotten a family member has gotten ALS diagnosis. And I've been trying to do advocacy and work on panels like this. And for me, the meaning taken from this horrible experience has been really helpful in my healing. So there's that. One of the things I want to say that's maybe apropos of nothing, but I think it was very helpful. It was somewhat helpful piece of information to me at the time. I was trying to figure out the whole durable medical equipment thing and what was covered and what wasn't. And I was going through the online website and being directed, to nowhere endlessly. And somebody suggested that I call my insurance company and request a special case manager to be assigned to us. And this was somebody who I could contact directly. And if I had a question, I could contact her and ask her, and she would get back to me. And it wasn't 100% useful, but she did answer a lot of my questions. And I think that would be, something to explore in improving that relationship, but at least developing a relationship between families and special case workers.
It's good to know about that experience. Yeah. Luna.
Hey,
One
yeah,
of the Luna, yeah.
sorry, no, if you're ready to move on, I can email you.
Okay. One of the other things that kind of balancing the chart review I was doing, which fits so much with the experiences that I think you guys have shared so far. I was also looking into, at least in our clinic, kind of what are the experiences of everybody working in our multidisciplinary ALS clinic on screening for addressing financial toxicity, if it ever ends up in the EMR, how it gets communicated among the team. At least in our clinic, as I mentioned, we have no formal screening, and it's often prompted by the patients or families, and there's a reliance on social work, ALSA, our clinic coordinator, to have resources for that issue, and then have the family follow up on that. So I think it might be similar to what some of you have mentioned so far. One of the, as we think about kind of how are we going to make this global change, I come at this from like a researcher perspective. So like, how can we get the data and really, show people that this is an issue? And some of the things that I think about are how are we going to consistently screen or measure for financial toxicity among people living with ALS? Are the measures that have been validated in other chronic illnesses or cancer applicable here? Because I think we all feel here that ALS is a unique condition, and better capturing what are the lived experiences of people living with ALS, in terms of those downstream impacts. How often is this changing people's mind about treatment options and things like that? And a point that was brought up earlier too, what are the lasting impact on our surviving caregivers? I so far can't find anything out there about that. And I think it's come up in multiple conversations that I've had with people about financial toxicity. So I think that there's that may be an area for research as well to show the really the ongoing impact, not just to patients but family members. So I've got some research ideas on this, and I've got a whole aims listed here, some proposed aims, but I was curious, it's a lot to read and I won't put you guys through that. But I was curious on coming to this group with some thoughts about research directions and the all-important question in research funding for research directions. Just kind of opening the floor on that. I see Christina's got a hand raised.
Hi, I was just wondering if you can go back to the Ames slide.
Yeah, I wasn't gonna belabor you guys and read all this, skip for the interest of time since we have 10 minutes left, but
Thank you.
some thoughts here were to describe the severity and impact of financial toxicity, both those objective and subjective components for patients and their caregivers, validate or build a scale to measure financial toxicity, and then really start to capture what are the impacts on surviving caregivers. But I'd be interested also, I mean, I've taken a lot away from the discussion so far today that are making me think to tweak this. I was curious, just for some thoughts here. Christina, yeah.
Oh, I had my hand raised because I just was trying
sorry.
to read the Ames, but yeah, I mean, I guess one thing that stands out is the discussion around the interface between, what we see when we're working with patients and care partners in the clinics and how policy affects all of this. And so this would establish like what you've got here, that good data to take to policymakers.
One of the things that I'm less familiar with is the interests of like the, I think we've used the phrase like foundations and philanthropic support. I know there's a lot of interest from a variety of groups, the National Academy, of course, on discussing cost of care concerns. But I don't know kind of where they stand on researching and gathering more data for these concerns. I don't know if anybody has any insights or thoughts, or if the data that we should be capturing should be a little different. So.
Astrid and I have talked about this previously, but I just wonder, and I'd be interested in other people's thoughts, about whether it makes sense during these interviews to kind of pitch potential policy solutions that we could advocate for, to the patients, people living with ALS or caregivers, to sort of see what they think about what impact that those changes could have. I think it makes sense to start at the beginning and try to understand the problem, but also I wonder, while we're doing these interviews, if there's an opportunity to kind of inquire about potential policy solutions and what might be most impactful.
As I think about kind of something that big, pitching policy solutions, is there a central resource for all the amazing efforts people are making on that front?
I know that the ALS Association has, an advocacy group. So that would be a good place to start, I think, to understand what they've been focused on. I know they're not the only group advocating for such things, but that might be one place to start. I don't know, Aditi, for example, do you have, I'm not sure exactly how much sort of work the IMALS does around advocacy for policy solutions, or
we do a lot of advocacy for policy solutions.
Cool.
And something that is challenging for us is determining which bills to support, because we are a really small team, or not support, but to really invest our efforts in. But this is definitely something that we would be very interested in exploring how we can best support the ALS community. And I'm also happy, Astrid, to have you come and present if you're interested to the IMALS community review team. It's a small group of patients and caregivers who help us decide whether to share large projects like this. And I feel like they would want to definitely support your project. So I can connect with you all to get that scheduled.
Thank you. I'll reach out to you. Suzanne, I see your hand raised.
So I have a question about this. It's such a thoughtful and important question to evaluate. And I think about, when we talk about from a clinician standpoint, a provider standpoint, and goals of care discussion is, risks and burdens of any decisions people have. And we hate to bring in, so often we focus on the clinical and the physiologic risks and burdens, but we don't often talk about the psychosocial risks and burdens of procedures and treatment options. And I think a parallel questionnaire, or something that could be done even in this group, is to survey how many ALS providers or neuropalliative care docs include this type of aspect or discussion in advanced care planning discussions. And I'll give a case that I just remember of a gentleman who went into a hospital and was kind of whisked from the ED into the ICU without his spouse and primary caregiver at his side, as he was hypoxic, asking if he wanted to be intubated and potentially trached or die. And he opted for being intubated and possibly trached. And the next thing they knew was his wife was talking to the case manager about planning on how to coordinate all the care and what that burden of care would be. And the distress that came out of that for everybody, including the patient. So I think that this is important. It's really important to quantify the amount of toxicity that the financial burden, that the reality of this financial burden. And I'll come back to also Max Harvey-Chochinov when he did his research on dignity therapy, that patients like to be treated with dignity at end of life. And I asked him, how did you get a multi-million-dollar NIH grant to prove something that everybody knows? And he said, unless we have the data, it's not true yet for many people. So the fact that you're asking this question, I think, is extremely important and very timely. And the other side of it is, are people including this type of questionnaire or discussion and goals of care discussion? And then, and even before and after we have the data that you have around the level of toxicity or the presence of it, will that change, or should it change from a medical ethics standpoint, the content of discussion? So that's just a parallel paper that I think could emerge, or papers. So
yeah, I think that's a whole series of questions, Suzanne, and that's one of the things that crossed my mind, initially, like, especially when I was in a similar situation here in the hospital, seeing people make sudden trach decisions. Are they thinking through the cost ramifications of this? Are they thinking through the fact of how many caregivers they're going to need? Can they afford that? And those are touchy questions to ask. As you pointed out, there's significant medical ethics component. That led me then to realize, I think there's so many questions in this space. Yeah, there really are. Sarah, you had your hand up next. And I do acknowledge we're almost at time as well. Thank you, Gail.
Yeah, I just wanted to add, I'm curious for ALS Association and I Am ALS, if there's crossover in working with the various state rare disease advisory councils, because that could be a space where, at least from a state by state basis, some of the policy initiatives and all those sorts of things. So just if we haven't sort of tried to connect with those councils, that's a good source as well.
Thank you. Yeah. And Farah?
Yeah, I'll just say, first of all, thanks. I'm so glad that this work is getting attention and that you're putting the time into it. My thought about the study would be, there's clearly so many people that are passionate about this being a problem. I think you could make it bigger. I think that you could coordinate an army of people to interview more people and put more power in your study. And I admittedly say that as someone who's been in private practice for a long time and is pretty naive to the intricacies of doing research. But go big.
I hear you. I wish I could. I'm almost 100% clinical. This is all in my spare time right now. So I would love to take this bigger. Thank you guys all so much for being here today. I have a whole sheet of paper just covered in notes and thoughts, and I'm really excited to see kind of what direction this can go in. And thank you guys all for your time and insightful commentary. So
Thank you so much, Astrid, for your great work in this area. Clearly, it's a topic that many of us feel strongly about. So thank you for highlighting it, and it will get all of us thinking more about it, no doubt. So I look forward to hearing updates and, hearing about how all of us can help you in your efforts. Awesome. Have a good rest of your day and week, and I look forward to seeing you all next month. We're going to talk about we're going to talk about intimacy concerns. So it'll be really interesting, a topic, I think, a relevant one for many of us. And I look forward to seeing you then.